Good afternoon again, everyone, and welcome to the first Emergency Manuals Implementation Collaborative webinar. I'm Jim Sachetta, a project manager at Ariadne Labs up in Boston, working closely with our Safe Surgery team here, and I'll be your host for this event. I have my colleague, Kyan Takahashi, here with me, who will be helping us run the webinar. And I wanted to say thank you all for joining us again. It's my pleasure to introduce Drs. Sara Goldhaber-Fiebert and Dr. Alex Hannenberg, who will be joining us today to talk about customization and modification of emergency manuals. Just to give you a little background on our two guests today, Sara is a clinical assistant professor at Stanford University School of Medicine in the Department of Anesthesiology, Perioperative and Pain Medicine. She's a co-founder of the Stanford Anesthesia Cognitive Aid Group and continues to develop and test the Stanford Emergency Manual. She's also a leader of the Stanford implementation of the emergency manuals and a co-founder of EMIC. Dr. Hannenberg is a faculty member in the Safe Surgery program at Ariadne Labs. His work is focused on the implementation of crisis checklists for critical event management in operating rooms and beyond. He's also a founding board member of LifeBox USA, working on LifeBox Safe Surgery programs around the world, with a particular focus in Latin America. He's clinical professor of anesthesiology at Tufts University School of Medicine and was associate chair of anesthesiology at Newton Wellesley Hospital. He's also a past president of the American Society of Anesthesiologists and now serves as the ASA's chief quality officer. Thank you both for joining us.
Pleasure.
Before we get started, I wanted to run through a little bit of webinar functionality with all of you. We're really hoping that we have a dynamic and interactive webinar this afternoon. But during the didactic portion, we will be keeping the phone lines on mute to cut down on any background noise. But if you have a question or comment at any point during the call, you can use the chat function that's located on the right-hand side of your screen, or the raise your hand function. You can see a little hand icon, and Kyan and I will be available to answer questions or unmute your line so you can ask your question out loud. If at any point you have any technical issues or concerns, please use the chat to host function, and Kyan will be able to assist you directly. So today we're going to be talking about customization and modification, but we first wanted to do a welcome and get an idea about who we have on the call. We'll do a brief history of EMIC, of how we started and who we are, and then we're going to get into a discussion where I'll interview Sara and Alex about customization and modification, their experiences with it, and then hopefully get some question and answer going with the audience. So to kick things off, we'd love to do a poll to just get an idea of who's on the call with us this afternoon. So if you look to the right-hand side of your screen, you should see a poll open now. So it would be great to just get an idea of who's out there. So we're just going to pause for about a minute or so and let you answer that poll. Wonderful. Thank you, everyone. So looking at the results, we have a mix of anesthesiologists and CRNAs, a group of others, a mix between people that have implemented and not, and of the people that have implemented, it looks like we have some successful implementers. So that gives us a good idea of who we have with us today, and we're glad that you've all joined us. So I want to pass things to Sara to lead us on a little bit of discussion and history about EMIC and where we are today. So Sara, handing things off to you.
You join us, and I'm going to make the presumption that most, if not all of you, know a little bit about EMIC from getting this webinar invitation via the EMIC mailing list and or the Ariadne Labs mailing list. I'm going to go through just a brief background for who we are as EMIC, which I believe includes all of you. So this is from our website mission that EMIC, the Emergency Manuals Implementation Collaborative, fosters adoption and effective use of emergency manuals to enhance our patient safety, with the initial focus in the arena of perioperative care and more and more sharing our lessons with other fields within healthcare. You can see below several of the goals, and I think that this webinar on customization fits well into both building our EMIC community to help all of you the best we can, and also to learn from each of you in your efforts and learn amongst and between each other, as well as the effective embedding in clinical use. So in terms of tools that we have representatives focusing on today, we're going to be talking a little bit about the Stanford Emergency Manual and Ariadne Labs Operating Room Crisis Checklist, but I just want to make the broad point that emergency manuals are not at all limited to these, and on the free tools part of the EMIC website at the top, you can see a drop-down and links to many other free tools and resources, some of which probably those of you on the call have either been involved in developing or testing or using or adapting, and I imagine that some of you have worked on your own or major adaptations of. There are others coming out of Europe and Australia and other arenas. So this is not at all limited to. We will be using these two as examples that have been downloaded and implemented many times, and one that I specifically want to point out because it fills a gap that neither of these address is the Society for Pediatric Anesthesia's national collaborative to work on a pediatric tool, which is a question we also often get of where should we start from if we're doing pediatrics. So in terms of the history, both of these groups developed these tools in parallel and then came together to work together on creating EMIC and working on implementation of either these or any other tool that people felt was the best fit locally. I think I can speak for all of us on the steering committee of EMIC that we don't feel that there's one right answer of what to implement, and that it's most important that a local group find the best fit for their institution, and then, as we'll be focusing on today, customize and modify so that it's an even better fit. Alex, did you have anything to add on that part?
No, you said it well, Sara.
So really, EMIC is about all of you and integrating all of the champions, the interprofessional teams, the implementers, and the users, and spreading these lessons. There's a bit of a list of our steering committee representation from all of these organizations, and we've had active involvement at every year of the ASA since 2013 when we formed. So first I want to go back in time, almost a century. This is a paper some of you may be aware of from Dr. Babcock, which our colleague and co-steering committee founder, Dr. Bill Berry, introduced us to. And it makes the point that the ideas that we are focusing on here are not new ideas. What is newer is maybe the time is right and the stars are aligning and all of us are working together to help actualize these ideas. But we think Dr. Babcock said it well almost a century ago, and you can find many of the aspects we focus on today in this one quote. If a response is not instantly obtained by simple measures, a fixed emergency routine posted on the walls of every operating room and drilled into every member of the staff should be enforced. Now, he was saying it a little bit in a top-down way, and as we've seen in modern healthcare, most of this has not occurred broadly, certainly outside of any ACLS and arguably even within ACLS type codes in and out of the OR. But you can see as we talk about, I'm going to flip back one more time, as we talk about these, the simple measures, the idea of having some sort of cognitive aid or emergency manual, he's talking about a poster here, but obviously it's grown quite a bit, to be agreed upon, a fixed emergency routine. He doesn't talk about the customization, but he's speaking more locally in this case before the idea is spread, and posted on the walls that's available and accessible somewhere where people need it clinically, and then drilled into every member of the staff. We've had many stories back from people that we downloaded these, we hung them in the ORs, what Alex has fondly called printing and plunking, and they're never used. So the idea that these don't jump off the walls themselves to treat patients, and they need to be familiarized and trained with. So jumping forward about to 2012 was when EMIC was formed, and this was in the aftermath of Dr. Atul Gawande's first of two recent keynote plenary sessions at our ASA conference, which happened in the fall of 2011. And a number of us on steering committee came together and said, we have these various tools being developed on different sides of the US, across the world. Let's come together to figure out the challenging and very relevant questions about how to implement and how to use these tools. And that's how we came together with a meeting in the spring of 2012 and then leading into 2013, where we began to see that year a lot more in both APSF newsletter forms of people being aware that these exist, as well as in ANA, Anesthesia and Analgesia, special article issue in fall of 2013, and that includes this conceptual article that I wrote along with my colleague Steve Howard about the concepts really included also in Dr. Babcock's quote there, that it might take to get these from existing in a sim center or development to actually being used in practice. And in that same issue, there were a total of 5 articles which focused on cognitive aids, crisis checklists, or emergency manuals, including one by Dr. Stuart Marshall summarizing a quite good review article summarizing all of the evidence to date, and a number of editorials there as well. So this was a year where a lot more people became aware of their existence as tools. And the biggest RCT to date, and probably most impactful in the literature, was this lead article in the New England Journal of Medicine written by Dr. Arriaga and team, including a number of the folks at Ariadne Labs from Harvard, which really showed well the tested difference between use and non-use. And here they looked at teams that served as their own controls, where they were using and not using the crisis checklist, with a huge decrease of about 75% in failure to perform key steps. So really compelling simulation-based data that confirmed a lot of the other observational studies and reports from simulation centers across the country and world that these things really do help. So here we are in 2018. The top link from the EMIC website is this orange and green banner, which you can click on to then get to another website called implementingemergencychecklist.org, a little bit more difficult to remember, so we usually send people through EMIC. That is the culmination of a 2-year grant study from AHRQ, where we came together and tried to understand via surveys and interviews how these are being implemented, how these are being used, what are the most effective techniques, and then bringing together a toolkit, a very practical toolkit for assisting people who are champions or interprofessional teams locally. And so this includes information on how to customize, but much more broadly, it includes a roadmap and sets of resources that you can pick and choose from, and please contribute to as you find newer techniques or different techniques that are helping or not. So we encourage you to take a look at that website. That's all cost-free for folks to use. And we will be having more webinars addressing different topics as folks are interested in them. Anything to add there, Alex or Jim?
No, I would say that the EMIC website and the Toolkit are both treasure troves of resources to make implementation easier and more successful, and recommend them both.
Okay, so we'll hand it back over.
Okay. So with that, today's focus among the implementation strategies to think about is the area of customization and modification. The production of the toolkit that Sara just referred to was based on surveys of almost 2,000 implementers of emergency checklists and interviews with dozens of them. So what I'm about to share with you about customization and modification is in large measure based on what we heard from people doing it and trying to do it. If there were a single guiding principle, I'd suggest to bear in mind when customizing these tools, it's to preserve the core and adapt the periphery. So what do we mean by that? The core reflects the design principles that produce usability, that result in a tool that can be effectively used in real-time management of high-pressure, high-stakes critical events. Adapt the periphery means to optimize its functionality and relevance to your setting. One useful resource in thinking about the core and the design principles is the checklist for checklists, which you can Google, but is also available on the EMIC website, which calls out very explicitly the principles of design and layout that were incorporated into the emergency manuals. So we're going to, I think, divide this discussion about customization and modification into two main themes: why customize, what to customize, and how to go about doing it. And the how to go about doing it part is an area in which I personally have struggled, and I think many others have, and we'll try to share with you some approaches to being able to do that successfully. So crisis checklists are useful and potentially improve patient outcomes in my institution, in Sara's, but in many, many others, which differ in important respects with regard to the patients being treated, the nature of care being delivered, and the resources available. So that is kind of an overarching reason, and we see crisis checklists being used really in all corners of the world, and they need to be different in those different settings. One good example of adaptation of the crisis checklist would be the Chinese language version of the Ariadne crisis checklist, along with Chinese language versions of Stanford's manuals and the pediatric emergency manuals. Dr. Jeff Wang in Orlando, Florida, worked with the major Chinese anesthesiology organizations to produce these and to make them available, again, free of charge in China on the website, where there literally have been hundreds of thousands of downloads. The manual on the right, the labor and delivery crisis checklist, was a product developed in my institution at Newton Wellesley, where we had obstetricians exposed to the OR crisis checklists who very quickly and correctly identified the fact that there were uncommon complex critical events occurring in the delivery room independent of surgery anesthesia, where a similar tool would be helpful. So I don't know whether you can read the items there, but shoulder dystocia, eclampsia, hemorrhage, and a variety of other obstetrical nightmares are addressed. Both of these and many others are available on the EMIC webpage.
And that would be under the free tools, just to add where to find those on the EMIC website page. At the top, it will say free tools, and you can click link to any of these.
Exactly, and so both of them, and really in a remarkably short period of time, the labor and delivery checklists have spread not only around this country, but overseas as well. But some of the reasons why one would want to modify the checklist would be that the way things are done at Harvard or at Stanford may not be exactly the way things are done in your institution. You may have different drugs available. You may have dantrolene instead of Ryanodex or the other way around. And clearly, picking up the phone, looking at the manual, picking up the phone and calling the blood bank at Brigham and Women's Hospital isn't going to be very helpful if you're in your community hospital in Iowa. The process of modifying, particularly if it is done in a multidisciplinary way, where nurses, anesthesiologists, surgeons, nurse anesthetists, and others participate, provides the participants in the modification with a sense of ownership, develops a larger and stronger band of champions for their use, and potentially instructors and trainers in their use. So there's just a multiplicity of advantages of undertaking this customization and modification process. I already alluded to the fact that in different cultures and different settings, some of the items are more or less relevant or need to be modified. The communication patterns in an institution, do you use cell phones, do you use pagers, do you have an emergency call button on the wall? You may want to think about whether those should be reflected in the protocol steps in the checklist. Physical considerations. Where are tools and resources needed in the management of emergencies located in your facility, and does every member of the staff potentially called upon to fetch that item know where it is? Malignant hypothermia cart, emergency airway cart, tracheostomy tubes, et cetera, et cetera. Is it necessary, and this is an individual judgment to make, is it necessary to indicate in your manual not only get the airway cart, but parentheses, it's located next to the recovery room or wherever it might be located. Putting your facility's name or logo on the cover makes it yours. It being yours is an important step in improving the likelihood of it being used when it is needed to help patients. I already alluded to the importance of relevant telephone numbers. This particular group of modifications that I'm addressing here, I would suggest are kind of the bare minimum. And there are a whole range of modifications that can be made, but with respect to usability and getting the most out of the checklists, these would be key. Do the medications specified in a particular protocol in the checklist match up with the formulary of what's available in your hospital? Do the instructions for the operations of a defibrillator or pacemaker device correlate with the type of equipment that you have available to you? When should a checklist call for some special resources or not? Well, it depends a little bit on whether TEE is readily available or cardiopulmonary bypass in your facility. It makes no sense to have an item that calls for those interventions if they're not available. And you may already have well understood protocols for management of fire or massive transfusion that probably should be referenced in the manual if those are things that people are accustomed to using. Now, as I said, personally, when adopting and implementing the Ariadne crisis checklist at Newton Wellesley Hospital, struggled with the modification a little bit and created some solutions that I thought would be worth sharing with you. The document, when it's downloaded, looks like a Adobe PDF document, but in fact it's actually created in a high-end professional design platform called Adobe InDesign. And I went and hunted down a graphic designer in the marketing department at the hospital to help me make edits. And if you are able to do that, that's a nice approach. Not everybody has somebody available to them with that skill set. The other approach was to create a template which captures the design features, the use of color and layout and font that is underlies the Ariadne checklist. And Jim, could you pull that up? So this is a blank, actually it's a PowerPoint slide, and if you're familiar with the layout and design of the Ariadne checklist, it'll look familiar to you. But we use this to create, to add to the Ariadne checklist, a checklist for management of obstetrical hemorrhage when we first launched, and have added several others since then that we'll give you a peek at in just a moment. Next. So these are the some of the modifications that I would say more additions and creating additional checklists. So the Stanford manual is 24, 25 clinical scenarios. Ariadne has about a dozen. There are procedures and services done in your facility that may not be covered there that may be very amenable to the use of a crisis checklist when adverse events occur. So just like our obstetricians reacted to exposure to the crisis checklist in the operating room, about a year later our spine surgeons did and said, you know, we very rarely have spinal cord ischemia, loss of neuromonitoring signals, but it really requires a very orderly and prompt response. Might that not be something for which a crisis checklist would be helpful? And so we sat down with them and developed it and added it to the manual. I've already described the labor and delivery checklist. The Institute for Safety in Office-Based Surgery worked with us, and using that PowerPoint template I showed you a little bit, created a manual of a checklist oriented to office-based surgery. So there's a great example of where the available resources are very different from what the designers at Stanford and Ariadne had in mind when we created the crisis checklist. And this is a set of tools adapted to that setting, and as you might imagine, places a great emphasis on orderly and efficient transfer to hospital from the office setting. The introduction of robotic surgery into a facility is another opportunity to use checklists to address the particular management of emergencies in that setting. So those are a number of categories of modifications and customizations, some ideas about the subsidiary benefits of developing ownership and champions for their use, making them more usable, and addressing the kinds of procedures and services provided in your facility that are at risk for critical events. Thank you.
Great. Thank you both, Dr. Hannenberg and Dr. Goldhaber-Fiebert. I now want to move into a portion where we're going to dive a little bit into this topic a little bit more and I'm going to try to, interview Sara and Alex here and see if we can find out a little bit more about some of this content. So I'm gonna dive in. We said earlier in the presentation that customizing and modifying helps to create buy-in. That's a bit of a unique term. I'm wondering if you could talk a little bit more about that and how important that is to implementation. Sara, why don't I kick that to you first?
The customizing and modification we've seen to be truly vital, and I think Alex started to touch on this in some of his intro. I'm actually curious to ask you guys on the line, have any of you had an example of either a customization really helping in the use or a customization process not being able to customize, hindering the use, or any comments from you guys to open it up for a moment on impact of customization on local implementation and use?
Thanks, Sara. So a couple ways we can do this. You can either use the raise your hand function and we can unmute you directly, and if not, we can also open up the lines directly and see if anybody out there has anything to say.
Why don't we try opening it up and see if we have feedback? We can flip it if we need, but I think we're a small enough group to
yeah, definitely
talk directly.
Lines are open.
Well, I can't speak.
Can you say who you are and where you're from, please? I heard someone say, I can speak.
Yes, you can.
Can you unmute Victoria again? Maybe that was her.
I can't talk.
I hear you saying I can't talk.
Now you
yes.
can hear me. Can you?
Okay.
Yes.
Yes.
Okay. Yes. So I have adopted an emergency manual, self-emergency manual.
Sorry, can you just say who you are and where you're from?
Yes, my name is Vicky Volkova, and I'm from Auckland, New Zealand.
Hi, nice to speak, Vicky.
Nice to speak. We spoke via email a number of times. What I had to do when the first article was published in Anesthesia and Analgesia, I took the manual and I modified it for New Zealand condition, meaning that I had to use I had to use British names for drugs. I had to use international units like millimoles per liter instead of milliequivalents and so on. I put my own phone numbers and so on. And I have to say that despite the fact that some people think that the manuals just hang on the wall, I know that people are using them. Sometimes they don't admit to using them, but then they come back to me and they say, I used the manual. So I have an old version that I sort of modified, but I need to modify it further. And I appreciate any suggestions.
Right. Actually, Sara, when we were talking about the options for modifying, you had brought to our attention a particular kind of adhesive label that I think we specify in the toolkit exactly what it is, that for minor things like phone numbers and so forth that you had found useful for modifying, just printing on those labels and sticking them on top of the checklist. Do I remember that correctly?
Absolutely. Yes, that's perfect. And sometimes these little details of just the how-to, the toolkit is peppered with these little suggestions of tips and tricks, including exact types of products that others have found to be useful. So I'll divide this a little bit into major and minor modifications. So correct me if I'm wrong, Vicki, but I believe that you're referring to having done modifications to a prior version, maybe version 1 even, or version 2 of the Stanford Emergency Manual. So we do suggest that if people have done something before but then want to renew it and make it up to date, we do suggest working from the newest version of whichever tool you're working from and rather than the other way around. And the basic reasons for that are design has changed and been very thoughtfully and positively impacted on both in all of these tools, I think, in the past few years, including things like working with NASA Human Factors Cognitive Aid Designer, Barbara Burian, who's on the EMIC steering committee now, and we've changed the layout, the phrasings of things, the bolding, all sorts of things, even beyond the literature updates and the content changes. So we highly suggest if you're going to start with a version 3, don't take your version 1 with local modifications and try to backfill it. Start with the version 3 or whatever version it is, the most up-to-date of your tool that you're intending to use. We find it very helpful locally, and others who have kept Excel spreadsheets or other lists of what their modifications have been so that you can easily find those and redo those. So for example, Vicki referred to changing all the epinephrine names to the word adrenaline, which is what is used in New Zealand for not just locally, but for the entire country there. So if you have a list of those, then you can move forward and modify them on each version. Now, what Alex was referring to was a more small and along the way modification. So if there isn't a new version, but you find that there's an important change in process, an example we had here locally at Stanford is we included on our hemorrhage massive transfusion guideline page the process for integrating with the blood bank and actually activating the MTG, the specific language, how you do it by phone, and then there was a system switch where that was changed to an EPIC order, and the order of things and where the blood is kept, whether it's in the OR fridge or at the blood bank, that all changed. And so we took an entire one of these stickers, and it wasn't just one line, but that entire half page, we put that over that page and didn't replace all the manuals, but replaced that local content to conform with the now new relevant local guidelines and language. So that would be an example of where we use those stickers. Others have used it also for an error that was caught after printing. We do always worry about errors getting through, and that is another caveat. When you modify and customize, you can cause a lot of positive impact, but to be highly aware that as human beings, it's very hard to see what we're not looking for. So I'll give you an example from ourselves that thankfully was caught just in time, but was truly a near miss, where Word had auto-corrected all of the mcg microgram epinephrine dosing to mg milligram, and caused us to then go to mu in the future for clarity, both for users and for Word autocorrect. But always beware that anytime you're making changes, it's an opportunity to introduce errors, and careful proofreading. We found printing out and proofing by hand with multiple people and being aware that harm in addition to gain can be caused during this process that you have to look out for. So that's one that I know institutions who have had similar issues and actually did catch an issue that was vital have gone around with these labels Alex referred to that are in the toolkit. They're wipeable, they're sticky, they're basically just sticky labels that are slightly waterproof and match the pages. Others have used binders, and instead of going with like a synthetic paper and bound, have used binders where you're able to switch in and out, and that's something I think Alex can also speak more to if people have questions on the different options and pros and cons of printing sort of locally in your institution with your local print shop, or with a honed kind of final or ready hanging version. So we're happy to address those types of questions as well. For the
that's another item on which there's a fair bit of detail in the toolkit. The contact information for the printing vendor that has been working with Stanford, and believe it or not, the actual staples catalog numbers for the binders, sheet protectors, and tabs that we used in producing ours locally. And so the pros and cons of electronic versus paper versus home printed versus professionally printed have a lot to do with modification and updating, and also usability. So that in implementing the checklist. Those are all things to think about with respect to how you approach the production of the material.
Thanks, Alex.
Vicki, I hope that at least partially addressed your question. Any follow-up on that?
And then using your toolkit and see where I can get to.
Excellent. And anyone should feel free to reach out if you need a sounding board or a little piece of advice along the way. Our goal is to empower folks and to share back together so we can all learn from each other's successes and challenges.
Thank you.
So I've got another question here for you. We've heard from folks that they don't think they need to modify these tools because Stanford and Harvard have put these out in the world and regard them as authoritative. Others are worried about copyright issues. How are we tackling that? What are we doing to change that thinking?
Well, I think I like to think that the factual content and the recommended practices that have been identified and sort of made the test for the Stanford producers and those here at Harvard are reliable. But there's a difference between reliable and appropriate, and I think most of the modifications we've talked about have to do with things that either fit or don't fit your needs and your settings, and there's no possible way that the checklist of manual developers are able to anticipate the scope of surgical subspecialty care you deliver, the nature of the equipment and drugs in your facilities, and if those are wrong, that seriously compromises the usability and the safety of using these tools. So I think nothing wrong with Harvard and Stanford, but it's not reasonable to expect that the local needs. And I'll just speak to the Ariadne Labs document with respect to copyright. It is produced, and the website clearly indicates that it is released into the world under what's called a Creative Commons license, which means that it's freely available for use. The only limitation is that it shouldn't be resold or used for commercial purposes. But with respect to adopting it, implementing it in your hospital, and using it in patient care, you're completely free to do that. We remind you in the modification process to be mindful of retaining the features that make them so usable.
I can speak to the Stanford emergency manuals. I think the group at Stanford started out with the weight of the concern overall within the group being for that people may mistakenly introduce either actual errors that I just spoke about, or destroy the design unconsciously to the extent that they would become much less useful. And the start of this was very labor intense on both the institutional side, I believe, seeking local modifications, and frankly on our side as well. Vicki went through this process of needing approval for all of the changes. From my work in implementation science and from working with EMIC and with the Ariadne Lab folks on the HRQ study that led to the Toolkit development, we have since met together as a group at Stanford, and in the past year switched over to a much more open and encouraging modification for the simple point that we want to make this as easy as possible, not to be an extra challenge and barrier in local modification. So they have always been actually under Creative Commons license, but in the past year or so have made them a lot easier to get this permission to go forward. We want it in no way to be a stumbling block. So they are shared as PDFs initially, mainly for the reason that we want to be able to have that conversation just over email of the caveats that both Alex and I have spoken to about design and usability and introducing errors. And now we'll send back a document sort of saying those caveats to the team, but empowering the local team and saying within that, make the changes you feel would be most useful. And please send a copy back of what you've done. Similarly, not for commercial sale, and just like with Ariadne Labs one, we encourage the adding of the local name, but credit should be given to whatever group has developed this, not just replacing the name with it. And beyond that, empowerment to make it locally useful. So that's been a major change in the past year based on user feedback that has now gone through the steering committee of the Stanford Emergency Manual Group. Any questions on any of that? Permissions for use? A Word document will be sent to anyone who inquires and asks for the easily modifiable version, so that you can make your own changes and then change it back to PDF for your local distribution. Any questions, comments, concerns on ability to modify, practicalities? Okay. I'll take that as a crystal clear.
Yeah, right, exactly.
Well, I'd like to go back a little bit, and Alex, maybe you can talk a little to this. So you decide you want to bring a labor and delivery crisis checklist to your department. It seems like a pretty daunting task. There's getting approvals, there's getting a committee together. Can you just talk a little bit about creating something new and what that process was like?
Sure, but just to clarify, the labor and delivery crisis checklist that we were looking at, I think of as being something that lives in the Department of Obstetrics and Gynecology. It is true that we imported a few of the cardiac event checklists from the OR crisis checklist and modified them for labor and delivery. But most of the events there don't really have anything to do with anesthesia necessarily. With respect to putting it in place, I have the good fortune of having spent my clinical career in a relatively small community hospital, about 250 beds, with a very compact bureaucracy. And as I said, the impetus for developing these tools for the obstetricians came from the obstetricians. And we formed a working group, multidisciplinary, about 3 or 4 obstetricians, a maternal fetal medicine specialist, midwife, and a couple of labor nurses. And I wasn't really there to deliver any obstetrical management content, but I was the checklist for checklist policeman in a sense, and would say that's too many steps, or do we need to provide some instructions about the use of this drug or that drug. But it was a really remarkable experience, and over a period of 4 or 5 months, we met every week or two, and these are all independent private doctors doing it on their own time. Nobody was telling them to do it, and essentially nobody ever missed a meeting. Everybody went home with an assignment to do a first draft on a particular topic, and each one would be iterated 2 or 3 or 4 times. Put the compilation, it was 17 events to start with, together, and then got input from a variety of obstetricians from surrounding hospitals, and essentially asking whether they found any errors, was there any guidance there that they disputed. Got to a point where we felt confident enough to put it out on our floors, sought feedback, and eventually got confident enough to ask that it be added to the free tools section of the website, where it has been picked up by a number of health systems around the country and some ACOG-related organizations as well. So I'm fortunate not to have had a lot of bureaucracy. We took it to a couple of committees, at the hospital, but the committees were populated with the same obstetricians who were insisting that they would benefit from these tools. One thing I'll just add about this one was that, we came to learn from the OR crisis checklist that having them in view as much as possible was an important strategy to increase the likelihood that they were in people's consciousness when they were faced with a clinical problem. And so one thing I'd recommend doing in the right settings, we made some extra copies and we put them in all of the obstetricians on-call rooms. So that if they were sitting around waiting for a patient to deliver, either because they were worried about that particular patient or just out of general interest, they could be thumbing through them at 3 or 4 in the morning and make it more likely that they knew that that tool was available in the delivery room should they need it.
Thanks, Alex. That's really insightful. I'm going to ask one more question to our 2 panelists here, and then I'd love to open it up to our audience. So, we talked a little bit about the challenges of modifying tools like these and format and software needs. Have you heard of any success stories other than your own of people out in the field that have overcome these barriers and maybe how they tackled it?
Well, with a nod to Victoria, I'll tell a story about a fellow Kiwi who did something fairly remarkable, who was teaching himself HTML programming and decided to take the entire Ariadne Labs manual and code it in HTML because he had a lot of interest in people being able to access it on mobile devices. So he was able to do that as well as produce the print copies for use in the operating room. And so he doesn't have to go find an InDesign graphic specialist to manipulate the Adobe files. He needs only himself or someone capable of editing HTML code. And I thought that was remarkably impressive and have developed an interest in publishing the next edition of the Ariadne Labs as an HTML file instead of an InDesign file. We'll see if we can pull that off.
Yeah, I think the most in-depth example I have of a institution we've worked with probably about 30, 40 institutions who have reached out for the Word document of doing extensive modifications that go beyond phone numbers. And the most extensive example I have is the Mass General Hospital that really took to heart the interprofessional committee to assess and choose a tool. And I think it's much less important which tool they chose, but the idea that of getting people together to choose what's going to work for us locally, what are the pros and cons, getting tools into people's hands and going through that process. My understanding is that there were a lot of pros and cons and very close between the two. Ultimately, they did end up implementing the Stanford Emergency Manual, but I think the rest of the process would be very similar no matter what someone chose. And they then ended up giving out to this significant committee with a whole timeline plan, physical copies, and having them mark up the sections and the events and saying what matches our practice, what doesn't, what would seem to create that cognitive dissonance or blockade to use in the moment. And they end up with an Excel document of changes to say what they wanted to make different, to make it easier, and then modified at least half of the events to make it really be in line with local practice. One of the biggest impacts that had was they had a lot of buy-in by the end of that people, there was ownership of really feeling it was their local version. And they also went through quite a significant process on the phone number side, not just slapping some phone numbers on the back, but really taking everything from the nursing side, the anesthesia side, the surgery side. What are your emergency phone numbers? What do you want to have access to? And so they now have it pretty ingrained in the culture, along with a lot of training work for this, that when someone walks into the room and they're the next person after every immediate action that needs doing as a hand action is filled, the next person's role, usually from anesthesia, but also from surgical residents and scrub techs and nurses at times, is to grab the emergency manual and to say, hey, do you want me to read from the emergency manual? Equally, we've heard people empowering, and we've locally been empowering all of our team members to ask at least the question, do you want me to grab you the emergency manual or the tool or the book from the hook, even if that person can't be the reader. So definitely successes wide and far of customizing and finding ownership. I want to leave time for you guys to be able to bring up your questions. Feel free to do it verbally, or if someone else is speaking, please do it through the chat function so that we know what your questions are.
Yep, Kyan, could you open up the lines again? If anybody has a question, the lines are open now. We did get a question chatted in from a colleague of ours, Paul Preston, who's wondering how best to integrate these with an EMR like EPIC.
I'm happy to take a first stab at that, and Alex, maybe you can chime in. So there is an active EPIC committee that's been working on integration into EPIC. They do already have available the different both Stanford and Harvard Ariadne Labs versions that you can use, or if you've customized your own, you could certainly quite easily make that available by hyperlinked PDF into EPIC so that there's a button. That's quite easy to do, and they're working on a nationally available version that you could start with if you haven't customized your own. Importantly, we think that should match whatever you use physically. If you do hand out pocket versions and or have hanging versions, which there are many good reasons to do as well, that should match. You shouldn't have one on physical and a different one electronically.
Yeah, I don't really have much to add to that except to say that part of the usability issue of a electronic, whether in EPIC or otherwise, version has a little bit to do with the available technology. So I have never really been that excited about giving up my EPIC screen with drugs and vital signs if I'm going to be pulling up a manual. I just don't have enough monitors available to do both at the same time. But if you're lucky enough to have that amount of hardware, then it becomes a more attractive option.
Thank you both. Let's open up the lines one more time to see if there's any last questions here before we close things up. The lines are open if anyone else has a question or comment or anything that they'd like to add.
So Sara, sorry.
Go ahead, Vicki. Go ahead, Vicki.
So Sara, if I need to, I'm going to go ahead and start with the recommendation of the third version, and I will be able to get in touch with you, wouldn't I, if I have any questions or stuff?
Sure, just shoot me an email now. I'll send you the Word version and the formal caveats, which we've kind of gone over, and you can start right on that.
Okay.
You're empowered to make the local revisions that would help you most.
Has to be
yeah, the other. The other thing I was going to add is that if you give us a second, here we go. A good place to share experiences and ask questions is available on the screen right now, which is the emergency checklist online community. And wherever it feels comfortable to do so, sharing your experiences and asking your questions there amplifies the benefit of it beyond an email exchange.
Okay, Thank you.
And thank you, Alex, for queuing that up. And not only that, but we'll also be sharing all of the resources from the webinar, the recording to this webinar, so you could share with your colleagues, as well as the slides, and any of the links that were provided in the webinar will be available in the community as well. So if you haven't already, please take some time to join. And I'd also like to highlight the forum aspect of that. So we've got a discussion forum built into the community, and Alex mentioned it's a great opportunity to ask questions. We've got many of the EMIC steering committee members in there, and they can support you one-on-one and be able to hopefully help you through any questions or challenges that you may have. I'd like to let you all know that we've got our next webinar scheduled for August 9th at 2 o'clock, same time, same day. We'll be talking about taking emergency checklists to new places, both geographic and different specialties. And finally, I'd like to thank you all, and I'd like to especially thank Dr. Sara Goldhaber-Fiebert and Alex Hannenberg for leading us today. It was wonderful to have you and bring your experience to this, to customization and modification, and share it with all of our participants today. So thank you again, and thank you all for joining. We hope to see you in August at our next webinar.
Thank you, Jim.
Thank you all.